We will continue our lecture. Now we come to Wolff-Parkinson-White syndrome is characterized by short BR, wide QRS, and delta wave. It is due to accessory pathway. Usually the conductive system, the impulse passes from the SA node to the AV node through three pathways, three bundles, and one bundle to the from right atrium to left atrium. Sometimes congenitally there is a new more pathway from the SA node directly to the ventricle without passing to the AV node. This is called Wolff-Parkinson-White syndrome. And this is example. You see the delta wave and very short BR, and the QRS is wide. Short BR, delta wave. Treatment is flecainide, is available in Egypt in rare centers in the ICC. It's called flecainide. Propafenone, Ritmonorm is not available these days. Amiodarone available. Digoxin or verapamil are contraindicated in Wolff-Parkinson-White syndrome. Catheter radiofrequency ablation is the standard treatment. Now we come to atrial fibrillation. Atrial fibrillation is divided into short-lasting, 1 hour, long-lasting, 48 hours. This is called paroxysmal. If it subsides by itself, it's called paroxysmal. If it subsides by intervention, it's called persistent. If it is very long, 1 year is called permanent, and the permanent is divided into two, less than 1 year, and there is possibility to revert to sinus rhythm, or permanent, and the doctor decides that there is no hope in reverting sinus rhythm and to continue rate control only. The new guidelines just downloaded, and I put it on my Facebook site. Is called Dr. Samir Rafla Lectures, and also on my Facebook page directly you can download it. This is example of atrial fibrillation. You can see F waves instead of the P waves, and the RR intervals are irregular. The causes of atrial fibrillation: organic heart disease as rheumatic heart disease, valvular heart disease, ischemic heart disease, hypertension, cardiomyopathy, atrial septal defect, constrictive pericarditis, myocarditis, without structural heart disease as alcohol, thyrotoxicosis, obesity, smoking, acute pericarditis, pulmonary embolism, sick sinus syndrome. And by the way, any patient coming to the clinic with atrial fibrillation, I must do TSH, thyroid stimulating hormone test. Another example of atrial fibrillation: the RR intervals are completely irregular. In the presence of accessory pathway, atrial fibrillation can be very rapid, more than 250 per minute, and this can lead to ventricular fibrillation. So any patient with accessory pathway developing atrial fibrillation must have scheduled ablation immediately. This ECG is very famous, and in some exams, some of the students said ventricular tachycardia. The RR intervals are completely irregular. It is wide QRS because of the accessory pathway, aberrant conduction. So never mistake this ECG with ventricular tachycardia. It is atrial fibrillation in accessory pathway. Any atrial fibrillation very rapid, the cause is accessory pathway. The other possibility is thyrotoxic crisis. Complications of atrial fibrillation: thromboemboli. If from the left atrium it goes to the brain, stroke, lower limb, isoimpulse in jumping to the coronary causing infarction, to go to the kidney. If in the right side, the right atrium will cause pulmonary embolism. The other complications of atrial fibrillation is heart failure and tachycardia-induced cardiomyopathy and complications of management as bleeding from warfarin. When to expect the patient will get thromboembolism is called risk factors for thromboembolism. High risk factors, major risk factors, previous stroke, transient cerebral ischemic attacks, old age above 75, clinically relevant non-major, heart failure, hypertension, diabetes, age 65 to 74, female sex and vascular disease. These are called SHAD-VASc score. If the patient is having heart failure, takes 1 score, hypertension 1 score, very old age 2, diabetes 1, stroke 2, vascular disease 1. Vascular disease means peripheral arterial disease, carotid disease. 6 takes 1. If the patient gets 2 or more, he is liable to thromboembolism and must take anticoagulants. When to expect the patient may get bleeding from anticoagulants is called has bled score. If he is having hypertension, abnormal renal or liver function, previous stroke, previous bleeding, labile INR means one day the INR is 1.5, another day 3.5. This is called labile. Elderly patient, drugs on alcohol or Voltaren. So if the patient gets 2 or more has bled score, is liable to bleed. Treatment of atrial fibrillation. If there are no or symptoms, anticoagulation and rate control. Disabling symptoms, you must resort to cardioversion. When to resort to cardioversion? If the patient is having unstable condition, pulmonary edema, myocardial infarction. Before doing cardioversion, you must be sure that there are no left atrial thrombi. Either the arrhythmia is just very recent, few hours, or you give anticoagulants for 4 weeks to be sure that there are no thrombi, or you do transesophageal echo. In some centers, they give anticoagulants for 4 weeks and then do cardioversion. Treatment by drugs for rhythm control is called rhythm control: amiodarone, flecainide, sotalol, propafenone. These are the 3 drugs or 4 drugs for rhythm control. For rate control, there is digoxin, metoprolol, verapamil. Don't mistake rate control drugs with rhythm control drugs. Anticoagulants are indicated in any patient with atrial fibrillation, whether rheumatic cardiomyopathy, prosthetic valve, prior to cardioversion by 3 weeks or 4 weeks. Anticoagulants as warfarin, new oral anticoagulants, rivaroxaban, apixaban. The new guidelines, I just downloaded it. Oral initiation of oral anticoagulants. Oral anticoagulants is recommended in patients with chronic clinical atrial fibrillation at elevated thromboembolic risk, SHAD-VASc score 2 or more. In SHAD-VASc score 1, the guidelines say SHAD-VASc score 1 is the doctor is allowed not to give anticoagulants. But once a patient with score 1, I did not give anticoagulants, and after weeks he came with hemiplegia, stroke. So I never, ever, even if SHAD-VASc is 1, I give anticoagulants. I do not stop anticoagulants. The question is, if the patient reverted to sinus rhythm by drugs or cardioversion, do you stop anticoagulants? If there is high risk, I do not stop anticoagulants.
ابيض يا سامي، انا فاكر كل ده في كتيبه.
ايوه، yes. Oral anticoagulants, some patients take 10 milligram instead of 20 milligram rivaroxaban, saying there is old age. No, the guidelines says A reduced dose is not recommended. Red, you must give the full dose. Residual ischemic stroke, thorough diagnostic workup is recommended. Adding antiplatelet treatment to anticoagulation is not recommended. It is, I saw more than once patient with anticoagulants and taking aspirin. This is not recommended. The importance of following the guidelines is the medical legal. In Europe, America, if the patient gets stroke, he will revise what you did. If you was doing anything against the guidelines, you may be blamed. Left atrial appendage occlusion, I saw more than one case of atrial fibrillation with cancer colon. Any anticoagulation, the patient bleeds. The management in this case is to do left atrial appendage occlusion. Management of bleeding on anticoagulant therapy is to give antidote. Primary prevention of atrial fibrillation, you can imagine what I will say primary prevention. Prevent hypertension, prevent obesity, maintain lifestyle, walking 150 to 300 minutes per week, avoid alcohol. And the first time I see sodium glucose transporter 2 inhibitors to prevent recurrence of atrial fibrillation. This is new. I finished atrial fibrillation. We come to atrial flutter. There is 2 P waves. You see 2 P waves. So any time you see a patient with ventricular rate 150 at rest, think in atrial flutter. The atrium contracts 300 per minute and the conduction is 2 to 1. 2 to 1 in atrial flutter is physiologic block. This is different from 2 to 1 from heart block. Another example of atrial flutter with given anti-arrhythmic drugs, so the conduction is not 2 to 1 but 4 to 1. The management of arrhythmia is by ablation in the following conditions: atrial flutter, atrial fibrillation, AV nodal re-entry, accessory pathway, Wolff Parkinson, ventricular tachycardia, and ventricular premature beats. We have advanced center for ablation in our university. Prolonged QT is a very important syndrome. It can be congenital or acquired due to some drugs. And you see from the beginning of the Q to the T is very long. Beginning of the QRS to the end of the T is very long. Prolonged QT can lead to arrhythmia. The normal QT is below 0.4. If it is above 0.43 second, 430 millisecond, this is prolonged QT. And this is another example of very long QT from the beginning of Q to the end of the T, very long. The management of the prolonged QT can lead to arrhythmia is called torsade de Bonne. And the management is maximally tolerated dose of beta blockers. This is example of ventricular tachycardia, wide QRS. If the QRS is 140 millisecond or more, this is definitely ventricular tachycardia, not supraventricular with aberrant conduction. The other differential diagnosis is the presence of AV dissociation. Here you can see that there is some P waves. So this is AV dissociation. The T here is different. So there is P wave here, AV dissociation. So this is ventricular tachycardia. This is non-sustained ventricular tachycardia. If the ventricular tachycardia is below 30 seconds, half minute is called non-sustained. Above half minute is called sustained. This is the torsade de Boine, typical in a patient with long QT. You imagine the QT from the beginning of Q to the end of the T, very long. The torsade de Boine is multi-morphology, polymorphic. Some of the QRS is above the line, some below the line. We at the end of the lecture, ventricular fibrillation, any arrest in 85% is preceded by ventricular fibrillation. The cause is myocardial infarction, pulmonary embolism, cardiomyopathy, congenital arrhythmogenic syndromes as Brugada syndrome, arrhythmogenic right ventricular dysplasia, prolonged QT, catecholaminergic ventricular tachycardia. This is ventricular fibrillation. Now we come to heart block. First degree heart block, prolonged BR. Second degree progressive prolongation of BR till there is failure of conduction is called Winkelbach. Another example of BR longer, 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 and then there is failure of conduction. This is typical Winkelbach. When you see arrhythmia, you must study the P wave and then the QRS and see who is married with whom. The P wave is regular. The QRS is regular, but there is no relation. So this is complete heart block. Another example, the P are regular. The R intervals are regular, but the PR are completely irregular. So this is complete heart block. I finished the lecture. I hope you got it, and you can find it over my page, Samir Rafla Lectures.